Good evening and welcome everyone to MAEA's Bionics panel. My name is Asif and helping me host today is Guillaume. Today we are joined by Dr. Fox from RMIT Academia, Dr. Pereira from the Bionics Institute, and Dr. Wang from Monash University. Welcome everyone. The format of today's event will include 15 pre-planned questions, which will be followed by a live Q&A. For attendees, make sure you pop your questions in the live Q&A on your right, which will be moderated and may be answered at the end. To start with, Kate, could you please introduce yourself?
Okay, my name's Kate Fox, and I guess I'm the Associate Dean of High Degrees Bioresearch at RMIT. But in my past life and in my current life, I do a lot of research into how do we make smart implants. So working on things like the Bionic Eye project and Smart Dental, those sort of cool things where we take biomedical engineering and interface it with the body.
Wow, that's cool. Thanks for that.
No worries.
Sarah, could you also introduce yourself?
Over to me. Sorry, you just dropped out a little bit, Asif. I'll assume you jumped across to me. So my name's Tushara Pereira. I'm from the Bionics Institute. I did my PhD in neuroscience at La Trobe University and jointly with the Murdoch Children's Research Institute. Then I had this wonderful opportunity to join the Bionics Institute Bionic Eye program. So I actually wrote the software that ran the Bionic Eye, which was, fantastic. That was a fantastic opportunity, and I learned heaps. And then I moved into movement disorders research. So I, at the moment, do deep brain stimulation, where we implant electrodes deep within the brain, stimulate, and we alleviate symptoms associated with Parkinson's disease.
Pretty cool. Thanks for the introduction. Yan, could you also introduce yourself?
Hi, I'm Dr. Yan Wong, and so I'm the head of the Monash Neurobionics Laboratory, as well as co-leading the Monash Vision Group. So my lab works on a lot of kind of brain-machine interfaces, cortical vision prostheses, kind of implants that go into the brain, as well as a lot of the neuroscience that goes around how prosthetics interact with the brain, how do we actually communicate or extract signals from the brain. So we do a lot of kind of basic neuroscience experiments all the way through to translational work to kind of help quadriplegics kind of think about where to move, the implants that kind of extract those signals, and then the therapeutic tools that will allow people to regain some kind of movement control.
Awesome. Cool, thank you all. It's great to see such a spread of knowledge on this panel. I'll now pass over to Guillaume, who will go into the first question. I think your mic is muted.
Thank you very much, Asif. So first question of the night, what in your mind is bionics? Dr. Kate, we'll start with you.
I always define bionics as anything that is able to communicate with the body. So anything that's implanted internally or externally that allows you to immediately contact tissue and make the tissue do something, in my mind, is bionics.
Thank you very much. Tushara, we'll move on to you next.
Sure. So that was a great answer, Kate. I suppose in my mind, it's sort of this combination of biology and engineering, but also I'd like to add the caveat that it's also for the advancement of human health. And, there's this other umbrella term called medtech, anything medical, the combination of medical and technology. So I suppose bionics falls under that medtech banner. Yeah, as Kate said, anything that augments the biological process, I would call bionics.
Excellent. Dr. Wong, do you have any final thoughts to add on this?
No, I think they're really good kind of answers. The, bionics, anything that kind of augments our ability to be human, right? So the devices that we kind of think of these days, bionic arms, bionic legs, cochlear implants, the deep brain stimulators, all these things that connect computers, connect artificial limbs to human tissue.
Thank you very much, everyone. Asif, you want to take the next question?
Cool. So how has bionics impacted you personally? We'll start with Dr. Kepler.
We go first every time. Obviously, I did biomedical engineering as an undergrad because I wanted to be able to use engineering to be able to change the human body. I wanted to make a real difference to the people out there. So personally, working on projects that allow you to see positive changes in people's lives really changes and motivates you as to why you love what you do. So yeah, I guess it gives you a much higher enjoyment about my work, seeing that bionics can really make that difference.
Cool. Tushara, do you have any thoughts on that?
Oh, absolutely. So I'd just like to echo what Kate said there. It's an extremely rewarding career. I mean, you meet people before and after surgery. You see this instantaneous benefit that the Bionics devices deliver. The way it's changed their lives, it's amazing. I was there when we implanted the first bionic eye, when we first switched it on. And, the woman that we implanted, Diane, she hadn't seen anything for 20 odd years. And all of a sudden, she was able to see flashes of light that we programmed into the bionic eye. I mean, that was an incredible experience. That was unforgettable. That's kind of why I'm in this field as well.
That's awesome to hear. Jan, do you have any additional thoughts on that?
So once again, I think they answered the question really, really well. I think the thing here is we're in the business to try and help people, right? So it's very rarely that you can kind of come up and work in a field that allows you to kind of take cutting edge science, really cool things that are in science fiction and apply it to, real world applications and actually be able to do it. And, Melbourne is a big part of that bionics field. We're at a time where these implants are becoming more and more mainstream, if that's the word to use. So we're seeing these big changes in people's lives because we can take, the most cutting edge technology in the world and interface it with the body.
Awesome. I'll now pass over to Yam, who will go into the next question.
Excellent, thank you very much. Now, you guys went on to this a little bit, where you talked about what you've worked on in the field of bionics so far. But I was just wondering if you can go into a little bit more detail, like what was your favorite project? What was your hardest challenge? Stuff like that. Dr. Kate, as always, you are first.
Awesome. So, I mean, I've been lucky because as I've moved through the different parts of my career and different employers, I've been able to cross many fields of bionics. So when I started, I was working in the bionic eye, a bit different to what you're going to hear from Tushara, but I was looking at how do I develop the materials that I can implant inside the body. So a very mechanical thing where we're literally making things, gluing up wires and then implanting them into various models to be able to see whether we could make things in the brain happen. Then I was lucky enough to work on the Smart Stent project, where we're able to, I guess, attach electrodes to a really common medical device, which is a stent that you put inside your body when you've got blood clots and that sort of stuff. So to be able to sort of see not only bionic eye applications, but also ability to, communicate with paralyzed patients and get them to talk to exoskeletons and that sort of stuff was really amazing. And, I've only ever been a periphery on the outside of these projects, but to be part of it, your parents are always proud. They see it on the news. They see, the academics being named, Australian of the Year and all that sort of stuff. And it's a really rewarding thing. And now at RMIT, I'm taking all that technology and instead, changing it over to 3D printed implants. So taking fracture fixation plates and be able to embed electronics and, control systems to try and improve bone healing. So I've sort of moved across 3 fields and 3 different applications of bionics.
That sounds absolutely amazing. I remember I remember reading an article when the stents came out, and it's just fascinating about how the whole process works, because it's you push the stent in, you expand it out, and then you get the feedback direct from the brain itself. Tushara, what have you worked on that you found truly fascinating?
So obviously the bionic eye, as I mentioned before, but also I spent a couple of years working on projects that would sense human movement. So we have a lot of patients that come in who have movement disorders. So things like tremor in their hands or an inability to walk. problems with falls and balance. So I've been developing instruments that can monitor the health of these patients. So, we use a lot of 3D printing. We do a lot of benchtop prototypes, quite rapid clinical trials to progress ideas. One of the biggest challenges, I suppose, that comes into such projects is managing this communication barrier, both between patients as well as engineers, but also between engineers and the clinicians. So I deal with a lot of neurologists, and sometimes it feels like we're talking two different languages. So it's quite interesting how the Bionics Institute, particularly, we develop our relationships with clinicians and patients. So that's just something that I thought I'd mention.
Excellent stuff. Dr. Wong, it's your turn now.
Yeah, so I work on similar types of projects, the Stentrode project, the Bionic Eye projects, brain-machine interface work. I'd probably just highlight that I work mostly at the interface of the brain and these bionics. And the reason for that is, even though we have these really cool technologies, we talk a lot about bionics and kind of the kind of next advancement of the field. But what I'd like to say is that we're really at the early stages of these devices, right? So like, if you look at bionic eye companies, there's more bankrupt bionic eye companies than there are ones that are still working. If you talk about brain machine interfaces, there's very few patients, if probably less than 2 or 3, that actually have these devices that can take them home, because they work really, really well in the lab. We can put 20, 30, 100 electrodes in the brain, but we have 100 billion neurons, right? So there's this disconnect between what we can do and what the brain really, how it controls our movements, how it controls how we see. And so what I work on is how we bridge that gap, right? How do we get from 100 electrodes to extracting the information of 100 billion neurons?
Not a challenge I think I personally relish. It sounds incredible what you're doing. Asif, the next question is yours.
So, sort of adding on to the previous point, what is the most interesting Bionics project that you have been involved in? We'll switch it up. We'll start with Dr. Wong.
I get to be first. So I mean, they're all interesting, right? And they're all interesting for their own reasons, right? Like, so, when Tom did the Stentrode, that's kind of just revolutionized the field because there's a whole new way to get electrodes in the brain. I mean, the one I work most on these days is brain-machine interfaces to allow quadriplegics to kind of regain control. So in this project, we put electrodes in motor cortex, somatosensory cortex, and try to decode thoughts about where to move. And it's the most interesting because it's such a complex problem, right? Like, you and I, we can all make these complex movements, really articulate movements, fine motor control, or really strong movements without even really thinking about it, right? I can pick up this cup of water without even looking at it, right? And have a drink while I'm talking to you, while I'm looking at you. And how does our brain do that, right? Like, I can look at the faces here and recognize your names without even thinking about it. But if I was to do this in a computer algorithm, it'd be the most complex computer algorithm and computer that we would need in the world, and we still can't do that, right? So what I like about Bionics is that it mirrors all these different fields, and like Kate works in materials and all these really cutting edge fields, and we have to put them all together. And so, understanding the brain is the most interesting thing that I think I've been involved with, and how that relates to brain machine interfaces.
That's amazing. Yeah, it just seems that Bionics is at the forefront of bridging that gap. So, Dr. Fox, what is the most interesting project that you have been involved in?
I kind of agree with Jan that they're all interesting in their own way. But I guess my first touch into it was this Bionic Eye project, and what made it interesting was we decided to go all out. So instead of taking what's a normal material, which is platinum, and using that for our electrode, we decided to make it out of diamond. And that brought a whole heap of challenges because no one was ever silly enough to decide that diamond is an electrode material. And we then had to take, very engineering people and then go across to the Bionics Institute and explain to them why our crazy engineering ideas could possibly be used in medicine. So, learning the I guess, the ways that engineers speak versus the ways that surgeons speak and the ways that, the guys working in the brain side of it speak was the biggest challenge of the lot, because we have no idea what we're all saying, and we sort of have to at some point find a common language. So it's really interesting. Anytime you're pushing the boundaries, trying new things, doing crazy things that everyone around you thinks is, pretty insane, is a really thrilling experience.
Exactly. That's amazing. Dr. Pereira, do you have any thoughts on your most interesting project that you've been involved in?
Sure. So just to add to Kate, I still sometimes don't understand what Kate says sometimes. It's mind-boggling. The most interesting project that I work on is always the one that I'm doing right now, because if it wasn't interesting, I wouldn't be doing it, right? So what I'm working on right now is deep brain stimulation, but it's a little bit more than stimulation, because recently we started recording as well as stimulating. So if you imagine we've got these electrodes deep in the brain, and I suppose for the past 20 odd years, the industry has always just been stimulating. And recently there's been a shift towards recording the brain activity as well as stimulating. And, perhaps we can figure out the deep dark secrets, that lie beneath the cortex in the brain.
Amazing. I'll pass over to Guillaume, who will go into the next question.
Thank you, Asif. So, as we know, manufacturing in Australia is kind of taken a nosedive, but we've always had I'd like to think, a fairly robust bionics industry. Where you have the bionic here, you have all of the work you guys are doing at the moment. I just wanted to know, personally, in your opinion, what do you reckon Australia is doing that stands out in bionics? Since we're testing this out, Tashara, would you like to start this time?
Gee, thanks, Guillaume. You got to give me the hard questions first. Wonderful. I suppose I read an article from Nature earlier this year, and Nature, there's this particular article tracked scientific journal metrics, and I was really surprised that Australia made it to their top 10. I think we're number 8 in life sciences. So, we're doing really well, and it's something that we've always done quite well, I feel, is we have wonderful ideas, we publish our results, we're certainly punching above our weight when you consider our population. Also, I suppose recently I've noticed that there are so many startups, particularly in Melbourne, and it's great to see entrepreneurship emerging here. I think I'll leave it at that.
I would be quite fascinated to hear what some of these startups are, but we'll probably leave that for the questions at the end from the students. Dr. Fox, would you like to take it next?
Yeah, so Australia made a really big decision about 10 years ago to try to keep up with the rest of the world in terms of bionics, and in fact, be the leaders. So it all started from $50 million from the Australian government that got spread between our Bionic Eye project and the Monash Bionic Eye project, and that sort of created this next generation of, I guess, Australian bionic researchers who have now gone off. The Smart Stent guys, they came out of the Bionic Eye project. The Bionic Eye project came out of the Cochlear project. All these great startups around epilepsy research and Smart Stent, they're all coming out of Bionic Eye researchers. So we've all sort of continued on that path 10 years later. And, as you probably guessed, I know Tashara and Jan pretty well because we've all crossed paths as we've gone. And we wouldn't be able to do any of this without the investment. We've now got, Melbourne in particular has a whole heap of funding sources from not just, the ARC and the NHMRC, which are, the Australian funding agencies, but plenty of investors trying to, support bionic research in Australia.
I gotta say, you're making the field seem very appealing at the moment, especially for soon-to-be graduating mechanical engineering students. Dr. Wong, would you like to take us out?
Yeah, so I do think that Australia does create some of the best scientists in the world, and the reason why bionics is kind of taken off in Australia is because we do have the appetite, or our hospitals have the appetite, our ethics boards have the appetite to take that risk of doing these surgeries in people allowing us to do these pioneering kind of studies, because not everywhere around the world would allow you to do this with, you know, because there is always risk when you do any of these kind of implantations. There are a lot of startups. You know, playing devil's advocate, I would say that the thing that Australia does not probably lead the world in is that we have amazing scientists in Australia, but we probably don't have that middle ground funding of taking, you know, crazy ideas into kind of the final commercialized product, where, you know, in Europe, in America, that funding is just a little bit easier to get, a little bit, you know, people are just willing to take that risk a little bit more. So Australia definitely has the best scientists, or, you know, some of the leading scientists in the world. And now we need to work on kind of the funding in Australia to kind of back us, not just the government to back us, but, you know, these commercial entities, venture capitalists to back us into commercialization.
And that comes back to the, you know, the lack of, you know, onshore manufacturing and that sort of stuff in Australia in all the fields, not just in bionics. You know, we've always been not so great at taking, you know, innovative ideas and translating them into an industrial relevant product.
I got to say, harsh but fair. Asif, the next question is yours, I believe.
So, speaking of current events, how has COVID-19 affected your work? We'll start with Dr. Fox.
Well, as you know, as RMIT students, COVID has had a huge impact on us as a university in terms of just being able to be on site in any way. So there's been no 3D printing. And I imagine you're going to hear from the other two that, you know, patients just can't come in. You know, having you know, children myself, and we've gone into the Royal Children's Hospital. There's nothing happening in those hospitals other than COVID care. But so for me, yeah, it's had a huge impact.
Yeah, it seems like the human element of bionics is really being impacted by the current pandemic. Dr. Wong, do you have any thoughts on COVID-19 affecting your work?
Yeah, so I think one of the big themes that might be coming up through what everyone's saying is that we work in big teams, right? From medical surgeons, medical doctors, to engineers in all these different fields, right? So we work in big teams together, and that's really hard when you have to do this via Zoom meetings and whatnot, right? Or when we're coming in to build an implant, and someone has to work on it on one day, then leave instructions for the next person to come in to do the next part. On top of that, there is no appetite to start very little appetite to do human trials right now, because hospitals right now, I think they're fine, but, you know, at any moment it feels like they could be under the pump. And so you don't want to be implanting someone with a risky surgery, or, you know, a surgery if there could be complications with COVID and things like that. So it's affecting our work as much as everyone else. But, you know, the good news for us, at least in this industry, is that we have jobs, right? And I'm thankful for that. And a lot of people, you know, are hit much harder than us, right?
Exactly. It seems like the issues of globalization for engineering is becoming more local. Dr. Pereira, do you have any issues with COVID-19 and your work?
Yeah, so again, you know, I have to agree with Jan and Kate. So I was planning to do a clinical trial, you know, commence a clinical trial this year, but I postponed that. And I actually, in March, I said, oh, you know, we'll think about doing it later this year, you know, perhaps October we'll start it. But then the second wave came through, and I'm like, now, maybe start of next year. So it kind of just keeps delaying on and on. Eventually I'll have to start it, you know, otherwise I lose my funding. So there's that element of it, but also talking about funding, you know, it's going to get harder and harder to get funding, I feel. There's been a lot of philanthropic funds that have gone towards COVID research, which means there's less money for us in the bionics realm. But I suppose personally, I was very fortunate because at the beginning of the year, I started a software project. And, you know, it was a very seamless transition for me and my team because we were working on software, and you can write software from almost anywhere. We were just able to continue on being productive at home. But I realized not everyone's in such a fortunate situation.
But I also think that, you know, COVID has actually done a good thing for bionics research and medical research full stop, because it's given the general public an understanding of the ways that engineering can be used to really treat a whole heap of problems such as COVID. I think it's actually been a bit of a godsend for the next generation coming through to see the application of engineering in medicine.
And also to add to that, kind of how fast, when you kind of fund science well, how fast we can do things like come up with 24-hour or 5-minute COVID tests, how fast we've come up with a vaccine that's gone into phase 3 clinical trials, right? Like when you fund science, we can do things very quickly. It's just that, most of the time we don't do that.
Exactly. So I'll pass over to Guillaume, who will go into the next question. Your mic's muted, Guillaume.
Still muted.
Still muted.
Don't worry, I'll get used to it eventually. All right, so this one is a bit of a longer question, so bear with me. To what extent can biology and electromechanical systems be integrated? Is there a foreseeable limitation? Namely, you can keep chucking servos and whatnot in a human body, but where do you draw the line? Dr. Wong, would you like to start us off?
Yeah, I mean, I think the premise of the question is maybe difficult, just because I don't think that, I mean, there's definitely a foreseeable limitation. We can't even put one in the body, right? You put one electrode in the body starts to break it down straight away. And so like with electrodes in the brain, it's like a stab incision into the brain. So you get bleeding, you get scar tissue, and the body starts to just try to break it down as quick as it can, right? So this idea that these bionics are clean, they replace, we're not at that point yet, is what I would say. So, I'll go back to the idea that the best kind of bionics that we can do in the brain anyway, or even in the cochlea, we can put 100 electrodes in the brain. And that causes a lot of damage and a lot of scar tissue and a lot of tissue response. Yet we have 100 billion neurons. So, 100 versus 100 billion, right? Like, so the limitation right now is we're only at the beginning of, we can't even put these few things into the body without evoking a huge tissue response. And that's because the body's just really good at breaking things down. Like, it's foreign, let's destroy it kind of thing. Same thing with things like lower limb or percutaneous kind of plugs that you might put in an implant into, they get infected, all this kind of issue, right? So I think what I would say is that we're really only at the beginning of this, and we don't know how far we can take, whether we can even take it to devices that will kind of operate to the level that we think we need to give therapeutic benefits. So in the examples of vision, someone who's blind is still very able-bodied, right? It's not like they're sitting at home doing nothing, right? They can walk around and do, live life to a pretty comfortable life and do things with the aid of a cane, with the aid of a dog. So can we even get enough electrodes in the brain or in the eye to give benefit that's significantly bigger than that? And that's our current challenge, right? Not where we can get to the end, but just can we even give a little bit of benefit right now?
In a way, that makes perfect sense. We were told in biology that the immune system is one of the world's greatest killers. Dr. Fox, do you have anything you want to add to that?
Yeah, I mean, as engineers, we really want to jam as much stuff as we can inside the body. Unfortunately, the body does not necessarily agree. So, as you've just heard, the auditory system has millions of neurons. The visual system has millions of neurons. And then we're trying to put in a device that has 200 electrodes. So we're never going to be giving back to the patient, what we consider as normal use of your eyes, your ears, your limbs. So it's about, what can we do to make the person's life, beneficial to them, not to us. It's very easy to make very cool things that are beneficial to us that has no actual use for the end user. If you look at something like, the one thing that pushed Bionics forward really quickly was, the unfortunate outcomes of war, where you're getting soldiers coming home, missing limbs, with weakened, limbs as well. And, the US government or whoever I don't want to finger point at the US government, but a government out there who wants to get their soldiers back out on the battlefield to continue to be soldiers, because that's what they've trained to do, has really pushed forward all these exoskeleton technologies, all these artificial limbs, to the point where some of these artificial limbs can put together a gun faster than a human can. So it's about working out whether the body and the brain can actually cope with parts that move faster than your arms would naturally move. So it's a really interesting ethical area, which is pretty much being dictated to by the body anyway. So the body's sort of stopping most of this technology going too far forward.
Yeah, no point giving someone a super powerful arm if the first thing they do with it is accidentally break their neck. Tushara, it's over to you now.
Yeah, I thought Jan gave a very good answer to this. I'd just like to add, in deep brain stimulation surgery, we drill holes into the skull. We do what's called a burr hole surgery. When you do that, the extracerebellar fluid leaks out, your brain kind of deflates, and then you're basically just stabbing an electrode, into the brain. So it does cause a lot of damage. Fortunately, the neurosurgical team are highly qualified, they're highly trained, they've done a lot of pre-surgical planning. They use CT and MRI to guide the electrode, but you could nick a artery. If that happens, you get hemorrhage, you can bleed out. So implantation of electrodes, implantation of bionic devices, it's not without risk. And the more things that we put in a human body, the greater the risk. So at all costs, we like to reduce the amount of hardware in the body.
Mm-hmm. Yeah, and just to add to that as well, it's not just the technology that's the problem, but like nobody understands how the brain works. I mean, this is a global challenge that we have. So even if we could design a device that could record from a quarter, a third, a millionth of all the neurons in the brain, we wouldn't know what to do with all this information. Like we just don't know what it means, right? The brain has its own code, and right now we don't understand what that code means.
I guess there's truth to the saying that it ain't brain surgery, right? Okay, well, Asif, I'm moving over to you. Would you like to take the next question?
Cool. So the next question is, what recent innovations have been made in the field of bionics? Are there any exciting experimental bionics that we may see during our lifetime? We'll start with Dr. Fox.
I guess for me, as a material mechanical sort of person, I'm always fascinated by how small some of these devices are getting. So if you think of when we started with the limitations in manufacturing and all that sort of stuff, you ended up with, a pacemaker was reasonably large. It had a pretty poor hermetic seal and, not much really happening inside it. But now we can have internal magnets, external magnets, batteries, wherever you like. The push forward in, the battery power and different battery technologies has just completely changed the way that bionic devices are made. The ways we can make electrodes now to be super small, needle electrodes, wire electrodes, you name it, that couldn't be done 10 years ago, makes bionics really interesting. We've still got the problem, of course, with materials not necessarily being found naturally in the body, and then the inflammatory reaction and all that sort of stuff we've talked about. But I do think it's really cool in terms of the exciting stuff we might see. I don't know, if you asked me 10 years ago that 3D printing would be a technology, I would have laughed at you. In university, we didn't do anything on, computer aided drawing. And now it's the way that engineering is completely run. So I can't predict. I mean, I won't go on a rant about bioprinting and how useless that is on this session, but I think new technologies are going to appear and push this whole thing forward in a way that we never predicted. Personalized medicine and digital health are the two things that will change this field.
It seems like the exponential growth of technology really will push forward bionics. Dr. Pereira, do you have anything to add?
Something that's was really interesting that happened maybe 2 years ago was that a deep brain stimulation device came out with Bluetooth technology. And I thought that was amazing. Yeah, we're finally getting some consumer tech into these bionic hardware. And obviously that Bluetooth technology was there to help the clinicians program the device, so we can program the electrical patterns that give the patient the therapy. And also it allows the patient themselves to control their device. So they have a little app on their phone or a separate patient programming device, and they can switch their system on or off, and they can even switch between different therapeutic programs. So sometimes if we put the lead, just off target, it can create side effects. And one of these side effects is a problem in speech. So if the patient wants to, give a seminar, for example, they can switch their program so they can alleviate, they can speak, but it also means that some of the symptoms might come back. So I think giving control of the bionic devices over to the patients, I think that's something that would be, a real innovation that I've seen in recent times.
It was really good to hear. Dr. Wong, do you have anything to add as well?
Yeah, so I think what I see as most interesting right now is that people are paying attention to the kind of the bionics field. And so I kind of think I used to have a friend who used to work for Boeing and made rocket ships that went up into space. And he used to always tell me that his job was just to deal with 40-year-old technology because you couldn't put anything new in these rocket ships. And I see the same parallels in bionics in that these implants, they're not complex, right? They're really simple technology and really old, but they're tried and true. And so what we've seen in the last couple of years, you see Elon Musk with Neuralink, is that they're taking kind of technology that may even be a decade old, but is like super exciting in bionics, and taking this technology and applying it to bionics. And so there's so many companies that are starting now, like NeuroDust, NeuroPixels, that are just taking, decade-old technology, but that's still 50 years in more advanced than the bionics we have now, to give us these big changes. And obviously there's going to be growing pains on whether they can take this new technology, because there's a lot of risk, a lot of money to prove these new devices work in bodies. These statements about the body as this environment that will destroy everything, as well as the implants can also hurt the patients. So, but I think that this kind of entrepreneurial spirit where people are just, the advancements in bionics happened 10 years ago, and people are just taking these advancements and applying them to different things. And so, especially in the last decade, what you'll find is, if you kind of look at the different kind of startup companies that have come about, is that the statement that your brain controls everything that you do, everything that you feel, everything that you experience or control happens via your brain. And so everything that goes wrong is typically associated with, or can be associated with, something that happens in your brain. And so there are companies that, for every single disorder that you can think of, are trying to start up companies that you can implant electrodes, modulate activity. I have bad memory. I can have an implant in certain different brain areas that might help me improve my memory, or depression, or every single one of these, pain, every single one of these kind of things, we're starting to see bionics companies try to tackle.
It's amazing. It seems like the bridge towards more exciting bionics is getting that to the consumer instead of just patients. I'll pass over to DM, who will go into the next question.
Thank you very much, Asif. Okay, so you guys have already talked about the challenges of neuroprosthesis with the electrodes and whatnot. So I'm going to focus mainly on the second part of this question. Could we one day see replacements of body parts that function exactly the same as a normal human arm, leg, so on, with the sensation of touch? Dr. Wong, I understand that you've had some work in this industry, so we'll start with you.
Yeah, so what I'd say is we already have robotics that could replicate a human hand. So 27 degrees of freedom, 28 degrees of freedom, they can give touch sensation, but we can't control those with our brain, right? So by 27 degrees of freedom, I mean, if I bend my elbow, that's 1 degree of freedom. If I bend my finger, that's another degree of freedom. Our brain, or the connection to the brain, we can control maybe 2 to 3 really well. So we've got this disconnect between what we can control and what the replacement parts can do. So we have already, the robotics can do this. We have early studies, so there's patients that we work with in the US who have electrodes and somatosensory cortex, and you can stimulate there and they feel the sensations of touch. But once again, it's kind of this, great proof of concept, but, it's too hard to allow them to take it home because the electrodes change every day. They, change over time. So you essentially need a team of engineers to calibrate this thing every day. You need a team of engineers to make sure the robotic arm is safe because it takes power, it's heavy, the brain signals are changing every day. And so by the end of it, you're like, well, if I have 10 engineers and doctors in the room helping to control this arm, why don't they just do the thing that the patient needs, right? It costs so much money to do this that, like, only it seems almost ridiculous. But we're getting to those points where what I would say is it's not the prosthetic limbs that are the issue, but the interface to the body. So the real bionic that is the problem.
Why get a $5,000 arm when you can hire a $50 maid, I guess. Dr. Kate, would you like to take it next?
Yeah, I sort of agree with everything that Jan has said around, we can make anything. Theoretically, anything can be made, but it's never going to replicate exactly what's been lost. All right, because you're implanting at the moment. You're implanting these technologies into end users that have gone years without sight, without touch, without whatever. So their pathways. And I'm no neuroscientist. The pathways have to be retrained anyway. They have some memory of what it used to do, but they've gone years without this working. So trying to replicate exactly the same way that those devices, well, the natural device worked before it was replaced, is a huge challenge. And it comes down to, the devices they're making are ones that, fulfill a purpose rather than a choice. No one's going to choose to cut their arm off and get it replaced with a robotic arm anytime soon.
Can't say I entirely blame them. Tashara, would you like to take us out?
Yeah, so I absolutely agree with both Kate and Jan. Definitely control the interface between the robotic arm or the robotic prosthesis and our body. That's the main hurdle. What else can I add? I think that's about it, really. I suppose there's two types of implants. You can have direct to brain, so you can implant electrodes directly onto the cortex of the brain, or you can get the surviving nerves from, if it's an amputation from the elbow, you might be able to connect to the nerves above your elbow. But it's that interface that's the real trick. Mm-hmm.
And of course, you read about the people out there that want to implant random things like RF chips inside their body and electromagnetic detectors in the back of their head. But they're the exception, not the rule.
Not a big fan of biohackers, I take it. That's fair. All right, well, Asif, over to you and your next question.
Cool. So the next question is, what sort of ethical issues do you face when making bionic designs? Also adding on to the point previously of the human connection on bionics. We'll start with Dr. Wong.
Yeah, so when people talk about the ethical issues, they often go to the extreme, which is like, well, once we get better vision, then you can see, is that like, you can get X-ray vision, or if someone is smart, like, very rarely have bionics gone that far. Maybe lower limb prosthetics, where you see at the Olympics that someone with a lower limb prosthetic can run a little bit faster than someone without. I think most of the ethical issues that we face day to day are kind of the realities of our technology. So things like consent of testing of our devices. So we work primarily in developing new devices. So when you get a patient, or when you get lots of patients, and they see kind of the hype of bionics, let's say someone who's blind or someone who's quadriplegic and can't move, they hear the hype of being able to see again, like, that a normal vision person might see, or someone who's able-bodied can move their arms and hands. And very rarely are we able to give, or no one is able to give anywhere near that kind of vision or that kind of movement ability. So the ethical issues here are kind of informed consent about patients. When they come to meet our surgeons, they're always in awe, right? This is like a leading surgeon in the world. They're talking about being able to restore vision, or restore the sensations of touch, or restore the sensations of movement. But ethically, how do we kind of convey that right level of, well, maybe you might get this kind of movement and it's a stepwise progression to this, and not overselling that work. And to me, that's always been one of the most ethically challenging things here, is that, you know, even in this discussion here, we're all excited by this bionic eye technology, but the reality is that someone's going to get implanted, have to go through the surgeries, have to live with this, and we're not probably talking about the best benefits. We could just be talking about some benefit or maybe no benefit. That's what we're trying to test out. And how do we ethically convey that? How do we get informed consent? How do we do that in the best manner?
Exactly. It seems like because of how recent this field, like, relatively speaking, is, getting those first experiments done is a big challenge. Dr. Fox, do you have anything to add on to ethical issues for Bionics?
Yeah, I mean, informed consent is the big one, because we all sit at home, we all watch science fiction movies, and we see all this amazing stuff happening. And then we see it in the newspaper, we go, oh, wow, in Australia, they're doing that stuff too. I need one. And the main problem we have is, you know, you have these great volunteers who will go in and they'll take the Generation 1 device. All right. And that's pretty much a safety device. So it doesn't really do much. If you look at an eye, it might give them light dark, but it will give them no capacity to read. What that then means is that when the next generation device comes through that, you know, has these, you know, abilities, those patients can't get that device. You know, they've already had an artificial thing pushed up against their, you know, the nervous pathways, and they can't possibly get the upgrade. So making them understand that there might be a better device later and you've got no chance of ever having it is actually something tricky. Of course, you know, the main one's always around treating kids. So things like Cochlear, where, you know, parents are making decisions on behalf of their their kids on, you know, whether or not this is a technology that will improve their life as the parents deem it. It's really tricky. And I know that, you know, in projects we've worked on in the past where, you know, it's got into the media and, you know, they've left comments on the website, you can sort of see that the misinterpretation and the misunderstanding of how medical devices and bionics testing really happens from the general public, because there'll be plenty of comments around, you know, I see you're testing this on humans. Can't you get on animals? Can't you get human volunteers to see whether this device is safe? Can you use, you know, a certain part of the population on this? So you're always on this edge of taking technology that the general public think they understand from watching, you know, movies and science fiction and, you know, Face Off, where they take the face and they swap and all that sort of stuff, and then putting some reality into the mix becomes hard. And then the other one's obviously the price of these technologies, where if you look at things like, we talked about the runners in the Olympics, you know, it's the well-funded, well-sponsored athlete that has these amazing devices, or the US returned soldiers who get this technology, compared to those that don't have that financial backing. That makes it a bit more difficult.
Yeah, amazing answer. It seems like making devices available to more people will need that human testing element. Dr. Pereira, do you have any input for the ethical issues?
Yeah, so we work with experimental technologies, but we don't always understand the biology. So Jan mentioned this earlier, you know, we don't understand how the brain works. In deep brain stimulation, we don't actually understand why the electrical stimulation has this effect on Parkinson's disease. We don't understand the therapeutic mechanisms. So sometimes when, you know, we are implanting these leads, we accidentally put it in the wrong spot. So we might accidentally put it in the adjacent structure. Now, when we stimulate these adjacent structures, we get side effects. You know, it might be a speech problem. Sometimes these side effects aren't readily apparent. So I know there's been case studies where patients have developed obsessive compulsiveness. You know, they've gone out and gambled their life savings, and you know, people think that it's because of deep brain stimulation. You know, it's changed their personality, it's changed their mood, and also we're starting to record from the brain more and more now. So, you know, what if we figure out a way to read a patient's mind? You know, what if we can read their secrets? You know, there's ethics surrounding those types of findings as well.
I've got a question for you. So hypothetically, someone gets a device implanted, and I do this in my undergraduate class. So they've got an epilepsy device put in, and they're part of the patient trial, and the epilepsy device comes in, no seizures for the whole 2 years of the trial. Now we get to the end of it, and the researchers say, okay, thank you for your time. Now it's time to take the device out. Where do we sit ethically? Because you've changed their lives, but then the liability of who then covers it when the researchers are well and truly gone. I think that's a huge problem.
Yeah, I agree, and we've had similar conversations in our lab. So once we go down the funding pathway, we've only got funding for maybe a 2 or 3 year study. What happens when the funding runs out? Generally in our clinical trials, we do explant routinely. But if the device is having a profound effect on that person's life, then ideally, you'd like to continue that therapy. But yeah, who does the maintenance? Who looks after the patient after the funding runs out? That's a great question, Kate.
Yeah, amazing answers, everyone. It seems like balancing that razor edge of advancement and the person itself, yeah, it seems to be a great challenge. I'll pass over to Guillaume, who'll go into the next question.
Thank you very much, Asif. All right, so this is for most of our student members out there. What are some ways for students to get involved in the bionics field? How would you recommend entering into the industry? What did you do to get to where you are now? Tashara, we'll start with you.
Sure. So if you're a student that's interested in the work that we do, I reckon the best thing to do is just contact us. You can email us, find us on LinkedIn, you can stalk us. That's fine. Also, coming to events like this, that's a great way to network. Although, virtual network, it's not the same thing, but really, come and engage. Yeah, I suppose that's really the best advice that I can give you. Also, find a mentor if you can. I know RMIT have a mentorship program. Join, find a mentor, start talking about your plans, your goals. That's the best way forward, I reckon.
Excellent, good to hear. I know a couple of people so far I've talked to have been talking about capstones. Does that in any way affect things? Like, have you ever had any experience with capstone projects?
Yep. So I've had a few students do capstone projects with me. Yeah, we do take on capstone projects. Mm-hmm.
Excellent. I know there'll be a lot of people happy to hear that. Dr. Kate, you are probably one of the best situated to answer this. How do you answer it?
Yes, I mean, the cool thing about, I presume everyone in the audience today are mechanical engineers or, engineers of some persuasion. But the cool thing about you guys is that you bring a whole heap of skills that most people working in this field don't have. So, your amazing CAD skills, your amazing, manufacturing skills, your understanding of mechanical properties actually gives you a huge strength to get into this field, particularly around medical devices and that sort of stuff, because you actually have a lot of skills that don't come from someone who comes from a physics background, per se, or a neuroscience background. So the best way to get involved is to really play up those skills. So go and do internships at these companies, because they're dying for people to mock things up in CAD and do all the FEA analysis and all that sort of stuff. Simple things like, if you want to put a lead onto these electrodes, how do you design a lead that can, sit behind the ear and, be put in using a surgical tool? There's all these problems that you guys have the solutions to. So take on capstone projects. We offer, undergraduate capstones, work experience placements, PhDs, you name it. There is plenty of stuff out there if you are value adding to a team. So yeah, reach out to people, and they've always got projects, paid and unpaid, just to give you a taste of what's out there.
Very good advice. Okay, Dr. Wong, over to you now.
So I don't agree with the Shara, please don't stalk me, but you can definitely email me or add me on LinkedIn. So like my lab, Monash, we offer summer scholarships. We take a lot of capstone students. You know, I take 10 odd capstone students a year. What I'd say is if you're interested in bionics, when I pick my students, I don't mind if you don't have skills in bionics. Where are you going to get them? You don't need those. But what I want to see is that you're passionate, right? That you've thought about what you want to do, where you want to go, that you're actually interested in the work. So many students that I've met, you know, they might have HD averages, but they kind of say they're interested in something, but they never follow through. So what I'd say is that it's about being interested in the field, right? And via a 10-minute conversation with a student, I'll know whether you're really actually interested in this, or is this just something that you picked up and you kind of, you know, a 5-minute kind of look at, you're like, oh, I might do this. So, you know, at some point in your careers, as you know, you're going to have to figure out where you want to go in your lives, be passionate about what you want to do. And in job interviews, in picking capstone projects, and all of that, it's really just about wanting to do it and showing that you want to be there to do it. Because, you know, I've definitely had students who I thought were really passionate about it and they never showed up, right? Or they showed up once out, and then I've had students who really followed through and are in the lab every day just because they want to learn more so than just their project, but they want to be involved in everything so that they can, you know, take that next step, get a job in a cool company and say that they've had that experience. So, you know, I'm always willing to take students in my lab who are passionate about it. Obviously, this is a hot area these days, and you know, I get a lot of emails to say, can I please work or do a project in this? And so how do you kind of get above everyone else? And to me, it's just doing a little bit of reading, having a think about where you want to go in your career and what you can kind of give back and what you want to get out from it. And most of the time, you know, our jobs, you know, Shara, Kate, my job is to educate students and help you get into this field. So we're more than willing to take you and teach you all these things. But for me, the way I pick my students is who really wants to do this and who can I actually help?
So they have to like what they do and be able to walk the walk at the end of it.
Well, I mean, the main thing, yeah, the main thing is that we also have to work with you, right? So like, there's nothing worse than having a student who hates their project, doesn't want to do their project, and I end up doing most of it and dragging them through, right? So having someone who just is excited to be there, is, you know, that excitement is contagious, right? So I want people who love the work, because then my lab gets excited, you know, they love to be there. Like normally we, you know, we're all together and we you know, work together and we learn together.
That sounds fair enough. Asif, the next question is yours.
Beautiful. So I think we touched on this a little bit before, but how is additive manufacturing important for the future of bionics? In my sort of report that I've done for assignments, I looked at introducing like porous designs and like different things that traditional manufacturing can't solve.
We seem to have lost Asif for a second there. So just to finish off what he's saying, there are certain profiles you can only make with 3D printing. Have you guys had any experience with that? And what is your current opinion on how important additive manufacturing is to bionics at the moment? Tashara, we'll start with you.
Sure. So I love rapid prototyping just in general, and you know, 3D printing's kind of revolutionized the way I do things. I particularly like to generate a lot of prototypes. I feel, you know, if you know, someone in the lab makes something in CAD and I show it to a neurologist, you know, they'll look at it and go, it looks all right. You know, we don't get a lot of feedback. But if we can quickly 3D print something, you know, even if it's non-functional, and then put that in the hands of the neurologist, you know, or put that in the hands of the patient, then we get so much feedback. You know, it's incredible that connection we have. You know, when you can actually touch and feel something, it's brilliant. So I like this, you know, process of, you know, design, print, give it to the end user for feedback, iterate, right? Go through that loop until you refine the technology, until you can actually get it into the clinic. So that's how I feel about it.
Cool. So thank you for the answer. Sorry, I cut out a little bit before. Dr. Fox, seeing as you have a materials background, do you have anything to input on this?
No, I'm big in additive manufacturing. I guess the main advantage we see, and it's not just in bionics, but in all sort of medical devices, is the ability for the surgeon to practice the surgery well and truly before they actually take off, the skull cap in a patient. That ability for the surgeon and the patient to understand the problem that's about to be solved. It could be a giant eye where you're showing where the neural pathway actually is and where you're going to implant the electrode. It could be a surgical guide that's going to help the surgeon put the device in the right place every time. It can be personalized technologies. So the lead wire is designed purely for that patient alone. The electrode array is contoured for that patient's brain or the biceps of the arm. Whatever you need. The ability to personalize things really is the strength of additive manufacturing in medicine.
Exactly right. Like in some of the commercialized products in America, like such as the Hero arm, they multiple arms, which is amazing to see. Dr. Wong, do you have anything to add as well?
Yeah, I think all I would add is that the way I see additive manufacturing these days is it's just another, like, as students kind of get older and whatnot, and we kind of progress through the years, it's just another skill now that I think all students need to have, right? So at some point it became, computer programming just became a thing that all engineers needed to be able to do, right? And I think 3D printing, additive manufacturing is becoming another one of those things because it's just another tool in our box that we can just pull out any point in time, right? It's not necessary. I mean, definitely additive manufacturing is important in specific areas of bionics, but for all engineers now, I'm just thinking it's one of those things where you just need to be able to do it because who knows what the problem is, but it's one of those tools that you can use to help solve it.
Right, yeah. And as Guillaume and I can attest, like getting into Bionics and having those skills of additive manufacturing, especially at RMIT with well, seeing as after COVID, looking how it will be, but getting into additive manufacturing in the A&P precinct and all that, it will be good to have those skills as a student. I'll pass it over to Guillaume, who will go next question.
Excellent. Thank you very much. Steve, I got to say that, yeah, working with the AMP and Makerspace has been a big benefit to being at RMIT. So the next question is, what materials are used in Bionics? Do these limitations heavily impact on feasible designs? For instance, you mentioned you work with diamonds, platinum, presumably a fair amount of gold. That stuff tends to be a bit expensive. How does that affect what you actually end up going with in the end? Tashara, we'll start with you.
Oh, wonderful. I don't really have a background in material science, but I suppose I've picked up a few things. Really what we go for is biocompatibility and also the ability to sterilize. We need both of those two things. Otherwise, we can't implant anything. So silicon, titanium, we make electrodes out of platinum, iridium. I think Kate, I'm going to handball this to Kate, really. Over to you, Kate.
All right, fair enough. Kate?
Awesome. Yeah, so really it's about exactly what Tashara is saying, it's about biocompatibility. So going back to also what Jan said earlier, we're a very stagnant field in terms of making, huge changes to what's worked in the past. So, the cochlear device is, platinum wires, platinum discs and silicone. All right, so that same technology just keeps getting pushed forward and forward and forward because it's got FDA approval. You don't need to go through the regulatory pathway all the time. So we are limited to, making capsules out of titanium, electrodes out of platinum, iridium, wires out of platinum. And yeah, they are expensive materials. But, if you look at, a cochlear implant, you're looking at 25 micron diameter platinum wire. So it's not a huge amount of material. Most of the cost actually comes in, the personal hand fabrication of the devices as we go. Yeah, so it's a materials problem. We're trying to get new materials. So I threw in diamond earlier. Carbon fiber is also getting a bit of a run. Gold and those sort of traditional antibacterial sort of materials. The problem we have is, the cheap materials, the coppers, just can't go inside the body, because the second a copper electrode or a copper wire touches biological fluid, bad things happen. Really bad things happen. And that's why the number one problem in bionics, other than that tissue electrode interface, is the encapsulation. So putting all the circuitry that is traditionally made out of copper and yucky things like that inside hermetic boxes that can't be touched by anything inside the body. And getting those things shut is a nightmare.
Not a sentence I expected to hear when talking about bionics. It's shutting the box. But no, I remember I looked a while back. There was a copper titanium alloy that they're using at the moment in 3D printing for implants. So a lot of interesting stuff with that. Dr. Wong, do you have any final thoughts to add?
Yeah, so I mean, bionics is a big word for a lot of different things, right? So it also depends on what you're doing and where you're doing it, right? So let's say if I'm implanting something in a muscle in a leg, I can be a little bit riskier in the materials that I use for that than if I'm going to do a craniotomy and put something in the brain, in which if that device leaks or has some kind of bad effect, the dangers of that happening in the brain versus the lower limb are much greater. So there's also this kind of risk-benefit analysis there, because a lot of the materials that we do use in the cutting-edge stuff are not happy in the body. So things like solder is made out of lead mostly, right? Implants and all the microchips that we use aren't biocompatible. So what Kate was saying is that we often put them in a box, and so that the box touches the body, but they leak. And if they leak, then lead might come out, right? So it's all about risk profile. How much lead is okay to put in an implant if it's going in the arm versus the brain, right? And these are things that we all do, right? We have to kind of come up with tables about risk management. Well, if this happens, how can we detect that happening, and so on and so forth. So it's not that you can't use materials like lead, it's just that you have to calculate the risk benefit. And things like, you might say, well, fine, you can use just tin solder. You don't need lead solder anymore. But if I remove the lead solder, then my solder joints might become more brittle. And so if I have an implant that I want to last for 40 years, let's say if I implant an 18-year-old soldier who comes back and has a life expectancy 50, 60 years that we might want to implant for, well, the risk of having a little bit of lead might mean that this implant is a lot more stable and might last 50 or 60 years versus tin, which might be a little bit more brittle. So it's not as simple as saying, lead is bad, don't use lead. This material is bad, don't use this material. These materials are used because they have really good properties. And so it's about finding that balance. And that may mean things like, well, okay, we need to use lead to make it more stable. So instead of putting the implant right on the surface of the brain where it's very close, I'll put it in a subscalp pocket, right? So that it's a little bit further away from the brain. So if it does leak, we'll be able to see that damage faster, and it's not going to get into the CSF, not going to get into the subdural space, and not be as bad effect. So it's really a trade-off analysis that we always do. We do these kind of risk analysis kind of tables all the time to be like, well, this material will give us better lifespan. This material will be more dangerous. What happens if we can change the implant out and around like this? So lots of different kind of things going around in the materials side of the field.
And when in doubt, cover it in silicone and cross your fingers.
Don't listen to Kate. That's not what we do.
It's fascinating to hear that, surprisingly enough, cost of material isn't your primary concern. It's mainly about what will be rejected, what's going to be dangerous long term. I'm going to pass over to Asif. He's going to do one more question, then we'll move over to student questions. Asif, all yours.
Thank you, Jim. So Murphy's Law says everything that can go wrong will go wrong. How do you guys work around that, and what do you do when it happens? We'll start with Dr. Pereira.
Thanks, Asif. So Jan touched on this just before, risk assessments. We do a lot of risk assessments. We have tight design controls. We do failure mode and effects analyses. We do extensive clinical trials. Before we even get into first in human studies, we do animal models. We do preclinical studies. If something goes wrong in a product that we've released to the market, then you have to issue a recall. We don't want that happening. That's kind of the end of your business almost if that happens. So yeah, we try to inherently design reliability into our devices.
Cool. Sorry, I think my internet's cutting out a little bit. Dr. Fox, do you have anything to add on to that point?
Yeah, I guess I was going to say things don't go wrong very often because, as Toshara alluded to, there's a lot of work that's done on the bench before it even gets anywhere near the end user. So, they'll be testing the leads to see how much mechanical rigidity there is. They'll be testing every element of this. And when it does go wrong, everything is so carefully tracked these days, independent, device numbers, you name it. So you can actually work backwards quite quickly to really make sure that any adverse events are picked up quite quickly. I guess the most important thing to know, other than that, all devices have passed rigorous safety checks, is that when it does go wrong, it's very rarely the device. It's often a complication in the patient that was pre-existing that that the surgeon didn't know about, or the surgeon didn't wash their hands properly, or it's some adverse event that is very rarely device related.
Yeah, it seems like again, going back to the human element, everything needs to be so very controlled. Dr. Wong, do you have anything to add to that point?
Yeah, I'd add that Kate won't make any friends if you say the doctor didn't wash their hands correctly. So I think that, like, you asked this question about students volunteering in Bionics labs, and what I think one of our best training kind of things in a Bionics lab is the way we think about problems and the way we think about, the statement that everything that can go wrong will go wrong. Like, we plan for that, and that's the kind of thing. And when it does happen, we train our students to have a way of thinking. Okay, so if something went wrong, how do you, it's not just, oh, everything went wrong and I don't know what it is, but we have a systematic way of thinking about it and how to solve that problem. Okay, this did wrong, so how do I test or the cause of that, and dot, 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 dot. So it's the nice thing about engineers and Bionics specifically, because our kind of error of margin, the margin of error is so small, is that we have to have very strict ways that we think, very strict ways that we run experiments, very strict ways that we build things and document things, right? So it's not like any other field where you can quickly just prototype something up, not really take documentation, not really think about what you're doing. For my students, it's all about the lab books. It's all about writing down exactly what you're doing so it can be replicated. Because even if you don't know what went wrong or how it went wrong, we can go back and we can look through our records. We can check all this. So it's in Bionics, and the students who, they may not go on and work in the field of Bionics, but what they learn is a structured way of thinking, a structured way of dealing with problems before they come up, when they come up, so on and so forth.
I'd just like to add, oh, sorry, Kate, you go.
So you go. I was going to say, I remember going through this risk assessment process back in the early days of the Bionic Eye. And the way we were holding our diamond electrodes on was basically a long titanium tack. So we're basically just sort of shooting something into it to hold it against the retina. And we had to go through this risk assessment, and we had to answer questions like, can the user jump on a trampoline? Can they use a drill above and beyond a certain power? And we had to go through and test all these things one by one in the most ridiculous circumstances, so we could say, yes, it is safe to go in a 4.5 Tesla MRI. It is safe to go on a trampoline. All these things. We need to test individual experiments for each and every one of those questions.
Mm-hmm.
Yeah, that's sort of exactly what I was going to say, Kate, because sometimes the biggest problem we have is with the user themselves. With deep brain stimulation implants, the neurostimulator is actually in close to their shoulder underneath the clavicle. Sometimes these patients, they get a bit finicky. They like to play around with their stimulator. It's a bit of a bulge. And sometimes these people, they can actually flip the stimulator. They can rotate it internally inside their body. So when you start doing that, you do that a couple of times, and it actually twists the wires that run up your neck, and it leads to breakages. So, that's something we didn't plan for. We never thought that a user would actually send the IPG, the neurostimulator in their clavicle, right? How do you plan for something like that? So that's always an inherent risk that people will find a way to break your product. And unfortunately, it's very difficult to plan for.
Yeah, and so often in these kind of risk assessments, it's not necessarily that you have to test every single one of these things, but at least if you've thought about it, then you can say, well, we don't know what will happen if you go in an MRI, so it's not MRI compatible. Just stay away from it, because you can exclude big parts of, you can just say don't jump on a trampoline. Like, obviously if you can show it works in a trampoline, then your device is even better. But there can be gray areas in how we design bionics because you can't test everything, but you can think about these things.
Then, like, comparing it to like other fields like aerospace and mechanical, that unknown human, just how do you plan for that? So now we'll move on to the student questions. So yep. So for the published questions, do you guys see anything that speaks out to you from the published web event Q&A?
So if I might jump in here for a brief second, the way it works is you should have a tab that allows you to list the student questions according to most liked. We want to answer if anyone who's watching, if you see a question you like it, you move it to the top of the list and we'll answer that question first. So go down. If you see a question you don't want to answer, it's fine. You just skip over it, but start from the top and work your way down.
I'm going to answer the one from Anonymous around shape memory alloys. They're actually, I mean, that's the whole premise behind the stent devices, where they're able to use nitinol, so a shape memory alloy that can change its properties around heat and conditions and all sorts of stuff. And they're actually using nitinol in their stents to try and better, I guess, fit against the vasculature in the brain. That one stuck out to me. In terms of projects around exoskeletons, we run a heap of capstones each year around finding ways to allow patients with cerebral palsy to be able to undergo tasks. It's actually the biomedical engineers, and I know you guys are mechanical, they actually do it their entire third year. They are placed in a company called Solve Disability Solutions, and then they make individual, prototypes for patients with cerebral palsy and other plegias to be able to do things like go to the pub and play pool. So we have heaps of projects at RMIT around exoskeletons.
I see a question that's liked about what you need to do to bridge the gap between kind of human body, or that knowledge gap. So I think it's kind of, there's a lot of kind of discovery science experiments is what we typically call them, where we're just trying to figure out what kind of parts of the brain are the visual parts of the brain and how these neurons work. So a lot of the experiments that we do is we put electrodes in animals, we put electrodes in humans, and then we just ask them to do different tasks. We show different visual stimuli, and then we try to use things like machine learning to kind of correlate that neural activity with what's being recorded in the brain activity. So my lab, I run cross between medicine and engineering, mainly because there is a big neuroscience question here of what do these brain areas do? So when Thushara puts electrodes into these deep brain structures to stimulate and shut them down, what does this brain area actually do? What does the neural activity, when the cell fires in that, what does it actually mean? And so we do lots of different types of neuroscience discovery experiments to try and kind of answer those questions.
Matthew, I see there's a question from you here about the potential use of genetic engineering in future bionic devices. So at the moment, one problem that we have is that we can't selectively stimulate or selectively augment neurons in the body. So when you're electrically stimulating, you are evoking a large population of neurons or nerves. So genetic engineering comes into the picture because there's this thing called optogenetics, right? So you can genetically engineer neurons to respond to light instead of perhaps electrical stimulation. So instead of using a electrical conduit, you might be able to use fiber optics to stimulate and evoke the neuronal pathways. So that's something that's in progress at the moment, and I believe, you know, in the future, you know, we might be stimulating with light instead of electricity.
Yeah, so the first companies that are already testing this in humans have started in the retina, and the benefit is that when you electrically stimulate, you kind of, your minimum number of neurons that you hit is kind of in the tens of thousands, hundreds of thousands. Whereas with light, you can actually activate, you know, 5, 10 kind of neurons. So it's 2 or 3 orders of magnitude better than what we can do with electrical stimulation. So the future is genetic manipulations like this. Whether or not people around the world want to have these genetic viruses put into their brains is another thing, because it's very hard to describe these things. So like one of the optogenetic vectors is via like a HIV virus. It's inoculated, so it's not actually HIV, but it uses that kind of cell structure to get into the brain. And so when you try to describe these to people, you know, do you want a virus going into your brain to change the cell structure, right? Like, even though you say it's safe, there's this ickiness factor about it, about, you know, whether it's going to replicate, whether it's going to get out, especially these days with COVID, right? Like, people just don't want to hear that.
So I see there's a question there on Neuralink, and I'll be very careful not to answer it because I trust their results as far as I can throw them.
Yeah, so the Neuralink data is not that new, right? So Neuralink purchased, so Kate kind of mentioned this idea of the US military DARPA funding agency funding a lot of this research. And so DARPA in the early 2000s funded my lab, funded a lot of labs to develop this work. And so what Elon Musk did is he came around and he bought 3 or 4 of these labs to form Neuralink. And so it's not that, you know, if you've been in this field, it's just really good marketing right now. So fine, you can kind of maybe implant 1,000 electrodes. You know, people have already done something like this, right? So his difference is he's using machine learning to kind of put electrodes around vessels, which may or may not have an effect on stability. But that's not the problem that we're dealing with right now, right? So the problem we're dealing with right now is that we can put 500 electrodes in someone's brain. There are people with Utah arrays out there with this many electrodes in there. But how do you teach someone how to use it, right? So this person who's been quadriplegic for a long time gets these electrodes in their brains. These cells are doing whatever they want. And now you're saying, please try to control this robotic arm over there, controlling these neurons in different ways. The people can't learn how to do this. So you've got to get away from the idea that, oh, it's just the electrodes. We need more electrodes, that's the problem. Even with 10 electrodes, we don't know what the neurons are doing. So if you give me 1,000, fine, maybe I'll find a special neuron that's going to solve everything, but probably not, right? Like, we've done this many, many times in many, many humans. The problem is not more electrodes. We look at the cochlear implant. The cochlear implant still has the same number of electrodes almost that it had, you know, in the 20s that it had 20, 30 years ago, right? More electrodes didn't solve that problem because we don't understand how the brain works. And that's what I'm going to keep saying here, is that fine, they found a new way to put a few more electrodes in the brain, but that's not the problem we need to solve anyway. So, you know, it's neither here or there.
There's a question there for me around how do I pitch using diamond as the electrode? Very badly. No, so the cool thing about diamond is because it's made similar to how you'd make an LCD TV screen. You know, it's a flat piece of material, and you can make it conductive and insulating by putting different dopants into parts of the material. So it's a really cool thing to upscale electrode numbers, and it's a cool material because, you know, carbon's more likely to be found in the body than anything else. But, you know, as we've sort of talked many times about today, the materials are pretty set in Bionics. It's very difficult to, you know, rock that apple cart. So we've got to show results about that our diamond electrodes can do things, you know, factors of 10 higher than what's already out there. So it's good. It's still going. It was sold to a Canadian company. They're using it now for sort of epilepsy and deep brain stimulation rather than bionic eyes. But yes, it's a cool material, and I'll chat about diamond all day, but you probably don't want to hear about it.
Can I talk about the AI question? Does anyone want to talk about that, or I
You can
do
take
it?
AI.
So
That's fine. I just want to say something real quick. We're not going to be accepting new questions. We're going to go through the remaining questions, and then we'll be ending the event. Sorry for interrupting, Dr. Wong. Back to you.
That's all right. We use machine learning a lot. I mean, machine learning goes from anywhere these days to like especially neural nets goes from anywhere between like one layer of a program. But, from bionic eyes of how do we, if you've only got 30 odd electrodes in the eye, so 30 dots that you can present, but 100 odd million dots that we can perceive like pixels in the world. How do you extract the most information from that to give to the patient? So we can use machine learning algorithms to try and extract information from the world. Things like the brain-machine interfaces, so the Elon Musk stuff, where we're trying to allow quadriplegics to control robotics and things like that. How do you take these neural signals or information from the brain and decode thoughts? So we use machine learning algorithms to do that. Machine learning and bionics, medical imaging, it's the big new thing. The question is, ethically, we're kind of just changing the topic a little bit, but ethically, we've talked a lot, well, the field now is talking a lot about how we kind of regulate this thing. So like often devices, bionic devices are fixed devices that you can test and you can say this works. Machine learning often involves some kind of learning about the environment and changes as it goes in the world. So how does the FDA, how does the Australian TGA regulate some software that actually learns as we go? And we don't really know the answer to this, because let's say it learns something bad and starts to do something bad. How do we regulate that in the world? Or how do you regulate some new kind of software? So that's kind of the big field for now, AI and bionics. How do you actually regulate it for sale in a commercial device? I'm staying away from the plants. I don't know, bionics and plants.
I can't see why not. That's called being engineers. If you think there's going to be a link between engineering and plants, I've got a capstone project for you.
No, that is actually a really good question. I know that in farming and food production, they embed sensors in the soil. They control the lighting. They control temperature. They control nutrients, so they can improve the yields of their crops. So hey, we can do it. we can put implants in plant.
I have a capstone project on sourdough starter where I want a student to monitor the humidity and temperature and growth rate of the sourdough starter, and then feed and stir and mix like in a closed loop system. So I don't know if that's bionics though, but I'd like to think that's close. Lab opportunities in my lab. So like for summer, it might have just closed, but we had some applicants from RMIT. We offer summer research scholarships. They're about $5.5 grand. So we normally take 2 students in my lab every summer. Every winter, we also take 2. I think it's a little bit less money because it's not as many weeks. I do a lot of final year projects. Kate and I, we were just talking about, I have a new PhD student who Kate recommended.
Stole my student.
She's amazing, so I'm happy to say I stole her. I will be happy to steal any other good student who but like, I mean, we all, like the good thing about this field is we want people to succeed in this field, and you will only succeed, we all do different things. Every panel member here does slightly different things. And so we know from a quick discussion with someone, if you're really interested in materials, I'm the wrong person to work with, but Kate will do some amazing things. DBS and clinical patients, movement disorders, if you're interested in that, Shashara is going to be the person for you, right? So I think a discussion with any of us, we're here to help you and help you learn. So most of us will kind of point you in the right direction. It's not just us 3 as well in Melbourne. We know I mean, I would say that we know almost all the bionics researchers in Melbourne, and not just Melbourne, but Sydney, in Adelaide. And so we can kind of point you in the right direction. And then it's up to you to make that connection and kind of sell yourself in a way that you can kind of, we want to hire you or we want you to volunteer in our labs.
I'm just going to correct that. You didn't steal the student. I've told her to go and do it with you. I probably shouldn't have made a joke about that.
I'm very happy to steal students from Kate, but like, don't get me wrong. If you want to come,
that's the thing. I mean, our RMIT graduates are fantastic. You know, everyone in this room listening to this conversation, you know, I'll back you in. I'll introduce you to anyone you want to meet, and they'll jump at you with open arms because you've got such a great background that fits their needs.
Yeah, it's not a big field, so we all know each other. Like before this started, Kate and I, Thashara and I were just reminiscing about people we all worked with who are now have jumped jobs and things like that. And you know, so it's a very small field, and we all work pretty well together. That's the nice thing about Bionics.
Yeah, there's no one that I don't like. I haven't met anyone that I don't like yet.
There's definitely people I don't like.
Yeah, it's definitely I don't like it.
Really?
There's plenty.
I need to go out more, I think, then.
If you ask me about certain people, I'll go like,
I've worked a little in exoskeletons, but not really with workers of heavy labor. I mean, this is a new thing, right? So if you look at the US, once again in the US, lots and lots of exoskeletons in Japan. You see exoskeletons in hospitals now to take weight. The issue with exoskeletons is typically power. How much power do they take? And safety, right? So you strap something onto you. How can you be sure that it's going to work all the time? How can it be safe? So on and so forth.
and the weight.
And the weight, yeah. Yeah, so a lot of the exoskeletons that are still in development, when you see kind of them working, very short battery life, so they get charged, they do something cool, and then that's it. Or they're still tethered to like the roof with power and things like that you don't quite see. So they're not practical. You know, you're not walking around, but maybe like there are environments, right, that will work. But normally, do you need an exoskeleton, or can you just get two people to do something, or can you get a lift to help you out, right? So like when you're lifting patients in a hospital, you typically don't do that manually anymore. You'll get some robotics that are fixed to the thing to help you out, right? A lift to help you out. So it's solved by cheaper and easier methods. Did I answer the bridge between human body and interfaces already? Or do you want me to talk about that? I see that on my screen.
I think you already answered it, yeah.
Yeah.
If you've already answered it, then that's fine. That means that was the last question. Congratulations. I will say though that for the exosuits, my summer job was making retaining walls. And let me tell you, when you've got a slope, you've got a narrow corner, you need to get a sleeper in, I would have taken 100 exosuits. Because you can't get two people in there. It's very awkward to set anything up. No, exosuits all the way for that. All right.
The question is, will your boss pay $10,000 or $50,000 for an exoskeleton, or will they just pay $10 an hour for someone else to do the job, right? That's the, you know, the hard thing.
An exoskeleton 15 minutes for $10,000.
My boss is my uncle, and he's the one who asked me to make him one. All right. All right. Well, with that last question, that's all the questions answered. Thank you very much to all the panelists for attending. Thank you much for giving us your time. To everyone who's watching, MAEA, we have a Discord that's going to be active till the end of the year. All right. If you have any questions about assignments or anything that still needs to be done. We also have our AGM on the 2nd of November, which all MAEA students have been invited to. Thank you everyone for coming, and I hope you enjoyed the event. Asif, did you have anything you wanted to add?
No, just to mirror those. Yeah, thank everyone for coming. It was really great insights. This is probably one of the most favorite events that we've done so far. With that, I guess we could end. Thank you, everyone.
Thank you for having us.
Yeah, thanks.
Yeah.
Nice
Thanks,
seeing you.
Asif. Thanks, Guillaume. Thanks, Asif. It's been a pleasure.
Pleasure to have you all. And of course, I see a comment from Harrison, who's the president, is recommending Asif for a job. It's always good to have connections.
Yeah. Cool. Yeah, I do my own like I mean like obviously not to the extent that you guys do, but my own sort of projects in my own time. So yeah, it'd be great to work in this field, honestly. Yeah.
All right.
There's an email so we can do.
Yeah. Amazing.
Anything else from me? Otherwise, I'm going to head out.
Cool.
Yep.
Right on.
With that, we'll end the event.